Tacting Time, Peak Module 12.0, presented by Hua Chang, Lindsay Ryan, Kate Stuber, and Tiffany Thomas. Peak Relational Training System is comprised of contingency-based programs, often called direct learning, which means all questions and responses need to be taught individually. Direct learning is a characteristic of early language acquisition. Unlike the traditional method of simply scoring occurrence versus non-occurrence, the Peak system incorporates a specialized scoring method that allows for detection of subtle changes in prompting and increases in independent responding. In learning how to tell time, this may help in learning other areas of math. For example, addition, subtraction, and skip counting by 5s and 10s. Acquiring this knowledge, especially at a younger age, will assist in other academic skills. It also may help kids cognitively and socially by understanding how much time has passed or how long they must wait for something preferred. Having this skill may be important for academics, behavior, and life skills in general. Each participant began on a different level and acquired skills at their own pace. In using the Peak system, it allowed the same type of treatment to work with participants on different levels. The Peak system designed by Dr. Mark Dixon provides multiple different modules spanning across many important life skills to add to an individual's repertoire. Each module is designed to teach individuals a new skill in a direct learning program specified to their individual needs. In 2002, Arntzen and Almas conducted a study involving TACT training in which they taught objects and letters to children 3 to 17 years old, some who were typically developing and some with developmental disabilities. The SD was presented and correct responses were reinforced. Their findings showed significant improvement in responses using TACT training. A study by Surokoff and Sturmy demonstrated positive results with training staff who implemented discrete trial training. The trained staff showed an increased performance with better results after training. All experimenters had experience utilizing discrete trial training, which increased reliability and was implemented correctly and consistently across experimenters. These studies are relevant to our program in that similar setup and procedures were used. We utilize the method of discrete trial training to help our learners appropriately tack time. 4 subjects ranging from 4 to 6 years old participated in our program. 3 of the subjects were typically developing and 1 subject diagnosed with autism and a developmental delay. The sessions were conducted in the subject's home environment or a caretaker's home. Each session took place in the same room with only the observer and participant present, and all distractions were removed. The rooms varied from subject to subject depending on what was convenient, what made them comfortable, and was least distracting. The observers held sessions at a table fitting for their size or on the floor of their home. All observers used an analog clock as stimuli and manipulated the clock accordingly. The goal of the program ranged from telling time in half-hour increments to telling time down to 55-minute hand. Our procedures were similar across the 4 subjects in that an analog clock was presented and a teaching trial was administered on the first session. After the teaching trial, the SD was presented and feedback was given based on their response. Correct answers were reinforced. Since all subjects were beginning on different levels, there were some differences in the procedures. For subject 1, the clock was a 20-inch clock with 2 metal hands. The clock was labeled 1 to 12 with minute ticks at every 5 minutes. He would accurately tell the hour in any minute from 50 to 59. For subject 2, the analog clock used had 2 different colored hands to help differentiate due to the child's level. The subject's goal was to master telling time to the half hour. For subject 3, an analog clock about 6 inches in diameter was used on an iPad. The stimuli presented were 15-minute increments in any order. For subject 4, the analog clock was about a 20-inch toy clock that could be manipulated. It had every hour marked and every 5 minutes marked with visuals. This participant began with the stimuli of reading to the hour, but then improved quickly and had phase changes to the half hour and 15-minute increments as well. IOA agreement was measured at 100% between observers for subjects 2 and 4. IOA was not measured for subjects 1 and 3 due to no other observer being available during sessions. A multiple baseline graph across subjects was used to make comparisons and evaluate results. Subject 1 through 4 listed top to bottom are shown. A delayed multiple baseline design was used for our project. 4 sessions of baseline data was collected for each subject with verification across all subjects. The x-axis is labeled with trial blocks and the y-axis shows the peak module score. In each figure, 3 types of scores are shown: baseline, treatment, and probe. Something to make note of when comparing data across individuals are the diverse learning patterns. Subject 1 and 3 portray a large jump from baseline to treatment, which indicates that these subjects may be quick to learn new skills. Subject 2 learned the new skill at a gradual increase, but once he attained the skill, he maintained the same average scores. Subject 4 had a history of learning quickly, so his therapist challenged him to learn many new parts within the skill. Subjects 1 and 4 had very large increases in accuracy rates from baseline to treatment, whereas subjects 2 and 3 gradually transitioned into learning the new skill. Due to time constraints, we were unable to probe 30 days after mastery of peak module, which is typical practice. Subject 1 was probed 12 days later to show skill maintenance. Results show all subjects successfully completed the program to mastery and maintained the skill of telling time well after sessions ended. Peak allowed for us to run the same program for learners of different skill levels and learning rates. Since each experimenter trained the participant in a different setting and started from different levels, procedural fidelity comes into question. There was no IOA between observers with different subjects, and there was no way to ensure each were administering procedures in the exact same way. Some individuals respond differently to various therapists. For example, some participants may respond differently depending on the gender of the therapist. We were unable to account for this possible variable. IOA was calculated with 2 participants with 100% agreement. However, the remaining 2 observers did not obtain IOA due to no other observer available during sessions. In addition, although each experimenter used an analog clock, we all used different stimuli, such as the type of clock and the different times used depending on the participant's level. In a multiple baseline design, prediction, verification, and replication must be present. In reviewing our results from the current study, one could say if the study were to be replicated, similar results would be seen. Even after treatment had ended, each therapist probed their subject at a later time. In this probe, all 4 subjects maintained the skill acquired through the Peak 12.0 module. Special thanks to our participants and thank you for your time.